Welcome to today's video, where we'll explore the critical role of the gut microbiome in health and disease. The gut has long been considered a source of self-infection, and its microbiome is crucial for maintaining health and immune balance. Dysbiosis, common in critical illness, disrupts the gut by reducing beneficial bacteria and increasing pathogens, leading to immune disturbances. The intestinal epithelium acts as a barrier, preventing harmful bacteria from entering the body, but dysbiosis weakens this barrier. Beneficial metabolites like secondary bile acids and short-chain fatty acids support gut health and prevent inflammation. Short-chain fatty acids also help maintain gut lining integrity and have protective effects on distant organs like the lungs and brain. Several factors like nutrient deprivation, sedation, opioids, vasopressors, and antibiotics disrupt the microbiome in critically ill patients. Pro-inflammatory cytokines worsen this by damaging gut barriers, promoting harmful bacteria over beneficial ones. ICU patients lose beneficial bacteria, like firmicutes, bacteroidetes, and see an increase in harmful types like proteobacteria. Up to 90% of good bacteria can be lost within 6 hours of a critical event, with harmful bacteria like enterococci dominating. The gut microbiota in critically ill patients often resembles that of decomposing bodies. Higher gut bacterial diversity, especially Prevotella and Bacillales, lowers infection and death risk, while Enterococcaceae increases it. Specific pathogens like E. coli, Pseudomonas, Klebsiella, and Candida can predict future infections. Enterococcus dominance is linked to worse outcomes and higher mortality. Early use of anti-anaerobic antibiotics has been associated with lower infection-free survival and increased mortality. It's still unclear if modifying the altered gut microbiota improves outcomes in critical illness. Therapeutic strategies for altering a dysbiotic microbiome include increasing health-promoting bacteria, reducing pathogenic bacteria, and modifying microbial virulence. The PROSPECT study, a large RCT, found no benefit for the probiotic Lactobacillus rhamnosus GG in preventing ventilator-associated pneumonia, VAP, despite earlier positive reviews. Other probiotics show preclinical promise, and a recent systematic review highlights current evidence on probiotics in ICU settings. Fecal microbiota transplantation, FMT, aims to restore ecological diversity in the colon and can be administered orally or rectally. Case reports suggest reduced diarrhea and septic symptoms, but further research is needed to validate its effectiveness and optimize delivery methods. Microbial consortia, groups of diverse microbes that function as a community, represent another option for ecological restoration, but they have not yet been studied in ICU settings. Selective decontamination of the digestive tract, SDD, targets pathogenic bacteria, such as proteobacteria, using non-absorbed oral antibiotics while preserving anaerobic flora. A meta-analysis of 30 RCTs found that SDD reduced mortality, relative risk 0.91, and had a 99.3% probability of improving survival compared to standard care. SDD was also associated with a reduced risk of ventilator-associated pneumonia and bacteremia in critically ill patients. The diagram depicts the gut microbiome in health, left panel, versus critical illness, right panel. Left panel, that is the healthy gut. The gut is dominated by obligate anaerobic bacteria, which play a critical role in maintaining epithelial homeostasis by producing microbial metabolites. Primary bile acids from the liver are converted into secondary bile acids by these anaerobes, and they, along with short-chain fatty acids, reduce inflammation and stabilize the tight junctions of the gut epithelium. Short-chain fatty acids, especially butyrate, are vital as they fuel goblet cells, which produce a protective mucus layer over the gut epithelium. These metabolites also enter the bloodstream, providing anti-inflammatory and immune-modulating effects on distant organs like the lungs. Right panel, it shows the gut in critical illness. In critical illness, the gut experiences severe dysbiosis, with the loss of beneficial anaerobes and the overgrowth of harmful pathogens such as Enterococcus, Staphylococcus, and Enterobacteriaceae. This dysbiosis results in reduced levels of vital microbial metabolites, leading to the death of goblet cells and disruption of the protective mucus layer. The tight junctions between epithelial cells destabilize, allowing microbes to translocate across the gut lining. This leads to local and systemic immune activation, inflammation, and harmful effects on distant organs due to the breakdown of epithelial integrity. The take-home messages are: the gut microbiome is essential for health and functions like an organ. In critically ill patients, the microbiome is disrupted early, with beneficial bacteria lost and harmful pathogens increasing. These changes are linked to worse outcomes and can affect organ function. Dysbiosis could be a treatment target, with methods like selective digestive decontamination, SDD, showing potential to reduce mortality. Probiotics have not been effective in preventing ventilator-associated pneumonia, highlighting the need for more advanced approaches. Fecal microbiota transplantation has worked in other diseases, but its role in critical illness is still unclear and needs more research.